So we can go ahead and start recording. Good morning. I have the pleasure of introducing Amanda Rogers. She is a graduate of the finest medical school in the state of Kentucky, and she went from our medical school to Washington University in St. Louis, where she did a pediatric neurology residency fellowship, followed by a neuromuscular fellowship in the pediatrics program there. So having a neuromuscular trained pediatric neurologist is a rarity. We had been searching for 10 years to find someone. Neuromuscular is a pretty broad field, and it's difficult enough if you're dealing with adults. For me, kids are entirely different animals, and so Amanda's going to be, I'm glad you're here, Amanda. Amanda's going to be talking today about congenital myopathies, and she assured me it's not just for kids. So here's Amanda.
Thank you so much, and thanks for inviting me to do this talk. So I don't have any disclosures that are relevant. I'm going to be talking about congenital myopathies today. And my objectives for the talk are to review basic muscle physiology and histology, to define the histopathologic and clinical features of the different congenital myopathies, to review care principles for patients with congenital myopathies, and then review pharmacologic treatment options for patients with congenital myopathies, both treatments that are currently available commercially and then also some that are under investigation. So what are the congenital myopathies? These are a group of clinically and genetically heterogeneous disorders. The most common presentation, as hinted by in the name congenital myopathies, is the hypotonic infant. But these disorders really, especially as we are improving our genetic testing, we're finding that they can present in childhood, adolescence, or even adulthood. Classically, this group of disorders was broken up into 4 broad categories based on muscle biopsy findings. This is changing a little bit as well as we are discovering that different genes can be implicated in different congenital myopathies, and so this may continue to change in the future, but we will go over kind of the classic categorization of these diseases today. Regardless of the age of presentation, the key clinical features of these disorders are those of really any myopathy. So low tone, proximal weakness, sort of neuromuscular flavor of cranial nerve, abnormalities including facial weakness, ptosis, and less commonly but possible ophthalmoplegia, depressed or absent reflexes. Of course, the reflexes could potentially be still present, but classically you would have depressed or absent reflexes. And then these disorders actually, and we'll talk about why a little bit throughout the course of the talk, but they follow a generally non to very slowly progressive course. So in contrast to muscle diseases like the dystrophinopathies, where there's a progressive deterioration in function over time, these patients typically, especially if they present in the congenital period, will show some improvement over time. Since the most common presentation is the hypotonic infant, and I know there's a lot of adult neurologists in the room, I thought I'd quickly review a general approach to the floppy baby. So whenever we're looking at a hypotonic infant, we first want to decide if the cause of hypotonia is more likely to be central or peripheral. The most important distinguishing feature between central and peripheral hypotonia in an infant is the strength. So if there's normal strength but low tone, it's more likely to be a central process, whereas if there's weakness, then it's much more likely to be a peripheral process. Central nervous system disorders are more commonly associated with an abnormal mental status, brisk reflexes, dysmorphic features, or other congenital anomalies, whereas peripheral nervous system disorders are more likely to have a normal, alert infant absent or reduced reflexes, although that's not always a hard and fast rule. And then there can be abnormal facial features, but they tend to be more myopathic with facial weakness, a high arched palate, ptosis, things like that. And then ophthalmoplegia is also possible. The CK should be normal in disorders of the central nervous system. In PNS disorders, CK is more likely to be elevated, but it could also be normal. And then in terms of the history, so CNS disorders are more likely to be associated with delivery complications, history suggestive of HIE, something like that. Classically, kids with neuromuscular disorders will have a history of polyhydramnios in utero and reduced fetal movements. Neuromuscular disorders, including the congenital myopathies, can present with multiple contractures at birth. Up in the left-hand corner of the screen, respiratory failure, feeding difficulties, and abnormal cry can present in both central and peripheral nervous system disorders. So if you have an infant and you suspect a neuromuscular cause of hypotonia and weakness, this is really your differential diagnosis. And the top 4 diagnoses listed here are going to be far and away the most. So spinal muscular atrophy, congenital myotonic dystrophy, the congenital myopathies that we'll get into more detail about, and then congenital muscular dystrophies. Even if you are dealing with an older patient, an adolescent or adult, your approach to diagnosis of these disorders is going to be similar. And your workup is pretty much going to include the following list of tests. So you're going to check a CK level. Especially in infants, you want to exclude other differential diagnoses, including spinal muscular atrophy, Prader-Willi syndrome, which when there's the congenital presentation of this, can really mimic neuromuscular disease. And then in the right clinical context, you may want to consider sending congenital myotonic dystrophy testing because this is going to be much more common than congenital muscular dystrophies or congenital myopathies. In the past, we would typically then proceed with EMG nerve conduction study, making sure to include rep-stim, maybe some muscle imaging, muscle biopsy, and then genetic testing. However, and I've kind of had this conversation with a few people this year already since I've been here, I really think that the appropriate approach to diagnosis is really going to include genetic testing much more early in the evaluation. Because we can get so much information from the genetic testing these days, it's really difficult to tell based on exam or EMG nerve conduction study what specific category of muscle disease you're dealing with. And so since we have sort of ready access to large panels of relevant genetic testing, I think that probably sending that first before doing these other, slightly more invasive exams makes sense. I think that there will definitely still be a role for muscle biopsy, and we'll talk about that kind of throughout the course of this talk. Before we get into the details of some of the specific congenital myopathies, I wanted to review a little bit about muscle anatomy and physiology for those of you who might not have thought about it for a little while. So on the left-hand side of the screen is a cartoon depiction of the muscle fiber. The sarcolemma here is the cell membrane of the muscle fiber, and obviously it separates the extracellular from intracellular components of the cell. Embedded within the sarcolemma is this complex of proteins referred to as the sarcoglycan or dystroglycan complex. And this is an important structure that sort of bridges the intracellular to extracellular components of the muscle fiber. So on the extracellular side of the cell, it interacts with the extracellular matrix proteins, including laminin alpha-2, collagen, all of these important structures. On the intracellular side, it interacts with dystrophin, which is important in bridging the gap between the sarcolemma and the sarcomere, which is the contractile apparatus of the muscle fiber, and it allows for the muscle fiber to contract and lengthen in order to generate force. The appropriate interaction of all of these proteins and structures allows the muscle fiber to have this dynamic movement without the cell itself going pop, so to speak. So a lot of cells in the body, you know, if they were subject to the stretch and the force that muscle fibers are subject to, would sort of open up and the cell membrane would be compromised. But because of these different structures, the fiber is able to tolerate that force. On the right-hand side of the screen is another structure called, or referred to as the triad and T-tubule. So again, up at the top is a depiction of the sarcolemma, the cell membrane. And as you can see, it actually invaginates into the cytoplasm of the cell while still maintaining an extracellular and intracellular divide. On the intracellular side of the cell, the T-tubule is in close proximity to the sarcoplasmic reticulum. And it's not showing it in this picture, but there will actually be a sarcoplasmic reticulum on either side of the T-tubule, and that makes up the triad. These structures are bridged by a few proteins, some of which you're familiar with, the dihydropyridine receptor and the ryanodine receptor. These are both calcium channels that when the muscle membrane is depolarized, open and allow for a large amount of calcium to be released into the cytoplasm of the cell, which is important for excitation-contraction coupling. So now that we've talked a little bit about anatomy and physiology, I'm going to go over some normal muscle histology and point out a few of the important stains that we look at when we're evaluating congenital myopathies and really any muscle disease on biopsy. So here is nice, normal, healthy adult muscle fibers, both in H&E and Gamori trichrome. You can appreciate that most of the fibers are about the same size. There's a little bit of variation, but nothing dramatic. There's not a whole lot of connective tissue between the muscle fibers. It's called the endomysium, and here it's relatively thin, just a little bit of separation between the fibers. And then there are nice kind of small, relatively uniform looking multiple nuclei in the periphery of the muscle fibers. These are two stains, NADH and ATPase 4.3. I'm showing you these stains because they help to, one, look at the oxidative function of the cells. So the NADH is one of our oxidative stains, and these help to distinguish between the two different types of muscle fibers. So you may remember there's type 1 and type 2 muscle fibers. Type 1 rely more on oxidative metabolism, and so on the oxidative stains like NADH, they're going to stain darker, as depicted here. The ATPase stains also, their function is just to distinguish between type 1 and type 2 fibers, and they take advantage of the fact that myosin ATPase will stain differently in the two different fibers at different pHs. And so in more acidic pHs, as shown here, the 4.3, the type 1 fibers will stain darker, and the type 2 fibers will stain lighter. And you'll see kind of as we move through the different congenital myopathies how these basic stains are used. So one more slide on pathology here is just to make sure everyone is talking the same language. I wanted to distinguish a little bit between congenital muscular dystrophies and congenital myopathies. Now, these can have very similar presentations, particularly in the infantile period, but there are some important differences to remember. So on the left-hand side of the screen here is a picture of dystrophic muscle. So this is what a muscle would look like if you took a biopsy of a patient with Duchenne muscular dystrophy. As you can see, in contrast to the normal muscle that we just looked at, the fibers are very different sizes. So there's lots of very small, round fibers, and then also a few large, dark, hypercontracted fibers. There's also some necrotic muscle fibers in here. There is a lot of increased endomysial connective tissue, so that space in between the different fibers is quite enlarged. There's not really a good organization of the muscle fascicles, and there's a lot of replacement of muscle by fat. Those big white globs in there are all fatty replacement of muscle. And so this is what you'll see, like I mentioned, in things like the dystrophinopathies. But patients with congenital muscular dystrophies can also have biopsies that look like this as well. And this is in contrast to what you would see in the congenital myopathies. So in congenital myopathies, rather than having this dystrophic appearance, you'll see these kind of odd, unique, different patterns on the biopsy, including centralized nuclei, shown in panel A here on the right-hand side of the screen. And these lead to centronuclear myopathies. NEMALINE rods in panel B, central cores in panel C, and then the last class of disorder is kind of a grab bag, but it's congenital fiber type disproportion. So this is one of those acidic ATPase stains down in panel D there, showing lots of dark fibers. Those are all type 1s. So there's many more type 1 fibers than type 2, which is abnormal. In addition to the muscle looking different under the microscope, the congenital muscular dystrophies tend to be more progressive over time, whereas congenital myopathies, patients can show improvement and be relatively stable over long periods of time. Congenital muscular dystrophies are much more likely to be multi-system disorders and involve the cardiovascular system as well as the central nervous system. Several of the congenital muscular dystrophies can have abnormal brain MRI findings, whereas cognitive function tends to be normal in congenital myopathies. And then lastly, the type of proteins that tend to be involved in the two broad categories of disorders are different. So in the congenital muscular dystrophies, these predominantly involve proteins embedded within the sarcolemma in that dystroglycan, sarcoglycan complex, or in the extracellular matrix like collagen 6 or laminin alpha 2. And consequently, you're much more likely to have a very high CK level in congenital muscular dystrophies versus congenital myopathies because that cell membrane is compromised, and so there's a lot of CK leak outside of the muscle fiber. In congenital myopathies, the proteins involved, as we'll talk about a little bit more, tend to be part of the sarcomere, so the contractile apparatus, or be involved in membrane trafficking and formation of the T-tubules. The congenital myopathies, as I mentioned before, are genetically heterogeneous. So lots of different genes can be implicated in each broad category of disease, and the same genes can cause different histopathologic subtypes. In the past, often the approach that would have been taken would have been to get a muscle biopsy, look at it and see, for example, central cores, and then go do testing for the RYR1 gene. Now that we can really test for all of these genes on a single panel, I think it's going to be sort of an opposite approach, where we do the genetic testing first. If we have a clear pathogenic variant or variants that explain a patient's phenotype well, then I don't think we have to do a muscle biopsy. But as I'm sure all of you have experienced, it's pretty common to get a variant of uncertain significance back on your genetic testing. And in that case, we might end up doing a biopsy to help to reclassify the variant as either pathogenic or benign. Now, it would be great if everyone just remembered all of these genes that I'm going to talk about at the end of the talk, and you were able to generate a great molecular differential diagnosis when you see a floppy baby or, a patient with a myopathy in your adult clinic. But you really don't have to do that, which is fortunate. So all of the genes here, except for these two that are blocked out by the lightning bolt, are included on the Invitae comprehensive neuromuscular panel. Many of them are included in the Perkin-Elmer panel. And so a lot of these sort of broad scope genetic panels that are either free or relatively affordable to patients will include all of the genes that you would want when you're concerned about a congenital myopathy. So moving into the specific diseases, first I'm going to talk about centronuclear myopathy. So the onset can be infancy to adulthood. And the genes involved in this class of disorders tend to involve membrane trafficking and T-tubule formation. Now, several genes have been implicated, but the ones that I want you to remember are MTM1 and Dynamin-2. So MTM1 encodes the myotubularine protein. It's X-linked, and we'll talk about that in a little bit more detail. Dynamin-2 is the dominant form of this and is the one that's more likely to present in adolescence or adulthood. The other ones to remember are Titin and SPEG. The only reason to think about those is that they have been associated with significant cardiomyopathy. And, rather than remembering, all of these specific genes that can cause cardiomyopathy, my approach and what has actually been published as, a rational approach to screening for heart disease in these patients is if you have a patient with a suspected congenital myopathy and you don't have a genetic diagnosis yet, go ahead and do some cardiac screening with an echo. Or once you do get your genetic diagnosis back, go look it up and find out whether or not it is associated with cardiomyopathy or not, and whether you need to be screening for that on a longitudinal basis. On muscle biopsy, the centronuclear myopathies are just like how they sound. They're centrally placed nuclei in the majority of fibers, as you can see here. So rather than those multiple eccentrically placed nuclei, they're all in the middle. And then there is type 1 fiber predominance and type 1 fiber smallness seen in centronuclear myopathies as well. Like I mentioned, the MTM1 related myopathy is the one this is kind of the classic textbook centronuclear myopathy that you'll hear about. It's relatively common. Pediatric neurologists will, potentially see this over the course of their career. And this is kind of the most severe flavor of congenital myopathies in infancy. It's X-linked, and the boys tend to have severe weakness and hypotonia with respiratory compromise very early on in life. There's often an antenatal history of polyhydramnios. There's often ophthalmoplegia, facial weakness, and bulbar weakness, making it difficult for them to eat. They typically do have cryptorchidism as well. So this is quite severe in the neonatal period. Female carriers can be asymptomatic, but we're finding out more and more that they can have a myopathy and be quite affected. So this is something that some of the adult neurologists in the room may see in their clinics. Last year, this group did a kind of deep phenotyping of female carriers with MTM1 related myopathy, and I think they looked at about 18 patients and sort of graded them from most mild, which were women who were still ambulatory with maybe just a little bit of mild proximal weakness or completely asymptomatic, all the way to women who were wheelchair bound. Now, they all had been ambulatory at some point, but over time, they did have progression of their disease. They tend to have proximal limb girdle weakness, as would be seen in other limb girdle muscular dystrophies. But they did also have some asymmetry, and that's what's being shown here in panel D and E. These women are not able to raise their arms up to the same degree on both sides. So there's some asymmetric weakness. And then also interestingly, another feature that was common was skeletal asymmetry. And so they would actually have asymmetry to the sides of their face and then also their hands, as shown in panels F and G here. And so that can be an important clue to the diagnosis if you are, taking care of a patient who has this finding. Most of these women who were more severely affected did have some respiratory compromise, but none of them had any cardiac abnormality. So the myotubularine protein, what does it do? As I mentioned, it's important in muscle fiber maturation and maintenance, particularly of the muscle membrane and the T-tubule formation. It's an enzyme, and so it is actually somewhat amenable to gene replacement, which is exciting. And I think that that's part of the reason the group that I mentioned before was looking so carefully at these female carriers, was because there is a gene transfer trial for MTM1 via an AAV8 vector that has shown some promising preliminary results. It's still ongoing, but they're full. They're no longer recruiting any patients, but this is likely to become a treatment option for this class of disorders, and then potentially for female carriers as well. Other treatment options in different genetic causes of centronuclear myopathy include pyridostigmine, which is an acetylcholinesterase inhibitor, typically used, as we know, in myasthenia gravis or other myasthenic syndromes. And the rationale behind this is that for many of these congenital myopathies, when you look at the neuromuscular junction, even though there's not specific proteins that are abnormal, or that should be abnormal based on the genotype, often the neuromuscular junctions are small and underdeveloped and are compromised as well. And so in animal models, there can be improvement of this with acetylcholinesterase inhibitors. And then there's also been some case series of patients who have shown improvement with pyridostigmine. So that is an option. The other drug that's under investigation still is an antisense oligonucleotide that's directed against dynamin 2 pre-mRNA. And this is a study that's actually looking at older adolescents and adults. And it's a multi-center study in Europe. I think they're looking to recruit somewhere less than 20 patients. But this is actively recruiting, and hopefully we'll be able to have some results in the next couple of years. So moving on now to central core disease. The main gene that I want you to remember related to central core disease is RYR1. So this is going to account for 90% of cases of central core disease. It is the most common cause of congenital myopathy. And it can cause disease when inherited in both a dominant and recessive fashion. Again, the classic presentation associated with a dominant RYR1 mutation is going to be this classic central core pathology and the classic clinical phenotype that we'll talk about in a minute. Recessive disease can also cause core myopathies, but you're more likely to see a multi-mini-core pathology on biopsy, and I'll show you a picture of that here in a minute and talk about the phenotype that you might see with that as well. So these are central cores. Cores are best appreciated on NADH and mitochondrial stains. There is reduced or absent oxidative and glycolytic enzymatic activity in the core regions, leading to this kind of pale halo. There's reduced or maybe absent mitochondria in the core. And the cores typically are in the center, but they can be more eccentric, as seen in a few muscle fibers here. They typically run longitudinally in the fibers and are more common in type 1 fibers. And so the targets can look similar to cores on biopsy, but they typically involve both type 1 and type 2 fibers and do not run longitudinally. So that can be a distinguishing feature of cores from targets. Again, as we'll see in all of these diseases, there's type 1 fiber predominance and type 1 fiber smallness as well. The typical clinical features of central core disease, it most commonly is going to present in the neonatal period with hypotonia, weakness, and maybe a little bit of mild facial weakness and ptosis, but it's not as severe as MTM1. So there's often maybe some respiratory compromise, but these are not children who are going to need a tracheostomy, such as you might see in MTM1. You can have skeletal deformities, or they can be totally normal. And then there's usually a more stable disease course over time where there's delayed developmental milestones, but eventually these children will typically walk and they'll typically maintain ambulation, at least for most of their life. Again, there can be an adult onset to this disease with kind of a mild limb girdle pattern of weakness. And then really not so much in RYR1, but in MYH7 and again Titin, you may see cardiomyopathy. And so if you have a patient with this, you at least want to look it up and see if you need to be doing some cardiac screening. This is a picture of multi-mini-core disease. So rather than there being sort of one core, either centrally or eccentrically placed in the muscle fibers, there's multiple cores in different fibers. And this you typically see with recessive disease rather than dominant. And the two main ones to think about here are, again, the recessive flavor of RYR1 and then this other protein called selenon, which used to be named SEPN1. So the recessive form of RYR1 tends to be more severe. And so this is going to mimic the MTM1-related myopathy a little bit more. There's going to be more weakness and respiratory failure in the neonatal period and more orthopedic deformities. Selenon is interesting in that it is one of these rare diseases that cause respiratory weakness out of proportion to extremity weakness. And so these children will have early respiratory failure, often require a tracheostomy, but they're able to become ambulatory. And so the picture here is a child who's, walking around with a trach, essentially. This gene also causes rigid spine muscular dystrophy, and so it tends to affect, again, the central and axial muscles a little bit more than the extremities. And so if you see a baby with, severe spinal involvement early in life, you want to think about this. There's a possible therapeutic role of N-acetylcysteine, and I'll talk about why that makes sense here in a couple slides. So zeroing in on the RYR1 gene, just because it is such a common cause of congenital myopathy, and it's a very large gene, 106 exons. And so in addition to, having a high rate of carrying disease-causing variants, you will often get variants of uncertain significance in RYR1 when you send a muscle genetic panel. It can cause autosomal dominant and autosomal recessive disease. And in addition to causing a myopathy, it can cause malignant hyperthermia susceptibility, exertional heat stroke, rhabdomyolysis, and atypical periodic paralysis. And patients can kind of have both phenotypes. So you can have myopathy along with malignant hyperthermia. The variants associated with dominantly inherited disease are enriched in 3 hotspot regions of the gene, and these account for 60% of causative variants. And there is some genotype-phenotype correlation here. So variants in the N-terminal or central portion of the gene tend to result in the malignant hyperthermia susceptibility phenotype, whereas those in the C-terminal tend to result in central core disease. This doesn't really hold true for recessive variants. These are distributed throughout the gene, and you're more likely to see, as I mentioned before, the multi-minicore or other histopathology rather than that classic central core pathology. RYR1, in addition to being able to cause multiple different phenotypes, can result in multiple different histopathologic subtypes and essentially can result in any of the histopathologic subtypes that we've talked about. So central core, multi-minicore, centronuclear myopathy, core rod myopathy, and congenital fiber type dysplasia. One thing that can be somewhat helpful in trying to sort out whether or not an RYR1 variant is relevant is muscle imaging. So on the left-hand side of the screen, there's kind of multiple views of a leg MRI, and the more black-looking muscles are more normal. So the rectus femoris, the adductor longus, and gracilis in the thigh tend to be more spared, whereas in the lower leg, the tibialis anterior is more spared and the other muscles are more affected. From what I've read, the rectus femoris is really the one that most people agree on tends to be spared in RYR1, and that's what this picture on the right-hand side of the screen is showing you, where all of these other muscles are kind of have increased signal and the rectus femoris looks normal. There are actually a few different treatment options and things under investigation for RYR1 myopathies. One is N-acetylcysteine, which is a precursor to glutathione, which is an antioxidant. And the rationale here is that, again, remember the RYR1 protein is a calcium channel. And so if it's compromised, there is this calcium leak out into the cytoplasm of the muscle fiber. and not enough to cause, persistent muscle contraction, but enough to result in increased redox reactions and generation of free oxygen radicals. And so the idea here is that this also is playing a role in the pathology and the abnormal muscle function. So there's strong preclinical evidence for improving function and actually histopathology in mice and zebrafish using N-acetylcysteine. It's a drug that's approved for other conditions, so we know that it's relatively safe in humans. There was a randomized controlled trial that was just published in March of this year, though, that unfortunately did not meet its primary endpoint for showing clinical improvement or a change. They measured this marker in the urine of oxidative stress, and they interestingly did show that all of these patients with RYR1 related disease had a high level of this marker in their urine compared to the general population, but there was no improvement of that marker over a 6-month time period of treatment with oral N-acetylcysteine. They did a lot of measures, and the 6-minute walk test and time to rise from the floor approached statistical significance, but didn't quite meet it. They had a pretty small sample size. It was a single center study, and so they're, postulated that a larger sample size may allow them to reach statistical significance. And they also talked about how, they gave an oral formulation of a standard dose to people who were of very different weights. And so N-acetylcysteine does come in IV form. And so I think there will probably be a little bit more investigation into this, but right now, the one RTC that we have for this did not show any improvement. Another treatment option for RYR1 related myopathy is oral albuterol. And the rationale here is that for whatever reason, treatment with albuterol increases the sarcoplasmic reticulum calcium pump. So this is an ATPase embedded within the sarcoplasmic reticulum that pumps calcium back into the sarcoplasmic reticulum after excitation contraction coupling. And so it helps to decrease the amount of calcium that's lingering around and lead to more efficient excitation contraction coupling. There was an open label study of about 10 patients, there were 13 patients, and 10 of them showed improvement subjectively and objectively after 3 and 6 months. One patient discontinued therapy due to perceived kind of tachycardia and heart palpitations, but otherwise it was well tolerated. And so they did recommend EKG monitoring prior to and during treatment for that reason. But otherwise, this is, a reasonable option to maybe give your patients a little bit of benefit. Pyridostigmine, again, similar to in the centronuclear myopathies, may improve fatigability. The only, published case report of this is just of 2 siblings, but it's generally a well-tolerated drug, and so it's something that you could try. Dantrolene is used for malignant hyperthermia. The mechanism of action isn't completely understood, but it seems to kind of blunt the calcium efflux of the sarcoplasmic reticulum by interfering with these channels. So it's definitely an important treatment for malignant hyperthermia. It may be helpful in patients who have RYR1 gene mutations and myalgias, but there's not really clear evidence for that. I don't typically use this routinely. And then the last class of drugs that is still under investigation are these molecules called RYCALs, and these are calcium channel stabilizers. And so the idea here, again, going back to that, the idea of that leaky calcium channel out of the sarcoplasmic reticulum, these have been shown to stabilize the channel and reduce calcium leak, hopefully, again, reducing oxidative stress on the cell and leading to better excitation contraction coupling. There's a phase 1 trial going on right now in adult patients with RYR1 related disease. They must have a genetic diagnosis, and then they actually look at the muscle biopsy and demonstrate that the calcium channel responds to this drug before including the patients in this trial. So that will be interesting to see what that ends up showing. Moving on to NEMALINE-ROD myopathy, this is the one, so, centronuclear myopathy, central core disease, they kind of have, it can kind of present in any way, but they tend to have the majority of patients following a similar clinical course, whereas in NEMALINE-ROD myopathy, you can have a pretty big spectrum from extremely severe congenital presentation with significant contractures, respiratory failure requiring a trach, to the complete opposite end of the spectrum where there's, history of completely normal development, normal functioning into adulthood, and then weakness developing in adulthood. Of course, the most common presentation is still going to be these congenital presentations, but there's quite a bit of variability here. There are 11 known genetic causes. Most of these genes encode proteins associated with the structure and function of the actin thin filament. The two that I want you to remember here are ACTA1, which is the actin alpha-1 gene, and then nebulin. ACTA1 typically causes disease in an autosomal dominant fashion, whereas nebulin causes disease in autosomal recessive fashion. So ACTA1, it's a very large gene as well. There's more than 200 variants described, but most of the disease-causing variants are missense. Again, the congenital onset disease is most common, but it can be very severe to a more mild, just kind of hypotonic infant, but who isn't requiring respiratory support and improves over time. These patients tend to have a little bit more central, axial, and bulbar weakness than extremity weakness, but they do have extremity weakness as well. They do typically get better over time and achieve milestones, and cardiomyopathy has rarely been described associated with this gene. Nebulin is also a very large gene, so this is another one similar to RYR1 where you'll get a lot of variants of uncertain significance. When trying to sort out whether a variant is pathogenic or not, in this gene, nonsense and splice site variants are most commonly disease-causing, whereas missense variants are less commonly disease-causing. What nebulin does, as shown in this cartoon here, is it actually wraps around and helps to stabilize the actin thin filaments association with tropomyosin. So it's another one of these sarcomere-associated proteins. There is a founder mutation in the Ashkenazi Jewish population, and so you will see this with higher frequency in patients with that background. And again, the congenital onset disease is the most common presentation. This is what NEMALINE rods look like. So this, again, is the Gamori trichrome stain, and you'll see sort of in the cap to the side right underneath the muscle fiber membrane, this collection of dark staining, sort of reddish purplish material. And these rods are composed of actin and other Z-line proteins, which kind of makes sense when you think about the genes that are typically involved. But what's interesting about these and what you have to remember is that they may not be present in the first few months of life. And so if a child gets a muscle biopsy at 3 or 4 months old, you may not see these, whereas if you redid the biopsy 3 years later, they might be present. They also can be missed so that you don't see them very well on regular H&E. You see them on Gamori trichrome and toluidine blue plastic sections, but sometimes you can really only see them on ultrastructure with EM. Again, you'll also see type 1 fiber predominance and hypoplasia in NEMALINE-ROD myopathy. There's also this interesting disease entity called sporadic late-onset NEMALINE myopathy, or SLONM. And this is something that you'll see in adults. It's not super common, but there's at least close to 100 cases described with the average age of onset of 52 years. These patients present with proximal weakness and can have significant axial weakness. So this is on your differential diagnosis for camptocormia. CK can be normal or slightly elevated. And what's interesting about this is that an IgG monoclonal gammopathy is detected in about half of patients. And so they can have improvement with immunotherapy or with stem cell transplant. This also can be associated with HIV, and those patients tend to have a better response to steroids. So again, another reason to think about, in your adult patients with limb girdle weakness who have negative genetic testing, it's still reasonable to think about doing a muscle biopsy to see if you see rods. And then finally, I'll come to congenital fiber type disproportion. So this is a little bit of a grab bag. There's not a typical genetic cause for congenital fiber type disproportion. And as we've talked about, we see this pattern in all of the other subcategories of congenital myopathies. But basically, when you have a biopsy that has this finding and doesn't have centralized nuclei, doesn't have cores, and doesn't have rods, then it gets called congenital fiber type disproportion. And it's defined by type 1 muscle fibers being 12 to 74% smaller than type 2, but on average, it's about 40 to 50%. The more dramatic the difference, the more severe the disease typically. There's more type 1 fibers than type 2 fibers. And as I mentioned, there's multiple different genes associated with this without one classic one to really point out to you. This is what it looks like. So this is an ATPase 9.4. So here the type 2 fibers are going to be dark and the type 1 fibers are going to be more pale. And as you can see, they're quite a bit smaller and more abundant than the type 2 fibers. You're going to take a sort of broad general approach to management that's going to be similar to all of these different disorders. You're going to screen for respiratory compromise in all of these diseases, and this is going to be the most common cause of morbidity and mortality. Even in patients who are breathing fine on their own and who might have a normal FVC in clinic, are at a higher risk of sleep apnea and nocturnal hypoventilation. And so you want to make sure to remember checking a sleep study if needed. They may need cough assist devices as well, especially during flu season, things like that. And you want to make sure to emphasize keeping up to date with vaccines, including regular flu vaccines in these patients. Nutrition is important, as in all muscle disease. You want to be assessing height and weight regularly, making sure that they are gaining weight and also not gaining too much weight. So I've sort of contradicted myself throughout this talk because I've said that congenital myopathies tend to not be very progressive, but then I've told you about a few diseases where people can obtain ambulation and then lose that ability over time. Often it's thought that this happens because patients sort of gain too much weight and have poor conditioning, because even though they can walk, they're not great at sports, exercise really wears them out, and so they end up having sort of these not so healthy habits. And this can be something that can actually take someone off of their feet if they gain too much weight. Bone health is important, and so you want to do regular vitamin D and calcium monitoring. Secretions can be a problem, particularly with congenital onset disease, and so working with a speech therapist as well as treating sialorrhea as needed. As is common in multiple other muscle diseases, dysmotility can be a big problem, and you want to make sure you're asking about constipation, GERD symptoms, things like that. As I mentioned before, cardiomyopathy is rare, but it can happen, and so you want to remember the genes that are associated with this and make sure you're screening appropriately. Again, if you don't have a genetic diagnosis, it's never a bad idea to get an echo. And then monitoring for orthopedic problems like scoliosis, contractures, and hip problems. And then again, physical therapy and exercise. There's always a role for this. Sometimes these patients will ask, do I have limits? And my answer is always, that the patient or child gets to set their own limits. So as much activity as they want to do is great, but you don't want to have them be in gym class and have their teacher, pushing them too hard, because that's just not appropriate. So my take-home points here are to think about this class of disease in patients of all ages, not just the hypotonic infant. There will likely continue to be a role for genetics and muscle biopsy. There are sort of a general approach to management of these patients, regardless of what the genetic diagnosis is, that is going to be multidisciplinary in approach. And remember to think about the heart. And then there are some pharmacologic treatments that can help with symptoms, particularly in RYR1-related disease, like we talked about. And there's, hopefully more on the way, particularly in the realm of gene-targeted therapies, which is exciting. So thank you guys again, and I'm happy to take any questions.
Yeah, Amanda, this is Dr. Wang. Thank you for your excellent presentation. I have a question, the congenital myopathy is extremely rare in adult patients. I probably have only 1 or 2 cases. So that's why I'm afraid I have missed some cases. But anyhow, there's no treatment anyway. So my question is, what kind of clinical features will make you think about a patient might have a congenital myopathy?
In adults?
In adult, yes.
Yeah. So I would think of it as being, mild weakness. I would think about it in a patient who looks myopathic, but who has, a pretty normal or only mildly elevated CK. If there's a little bit of facial weakness, that's kind of the patient where I would think about it. And I think, sending on your patients who you followed for years and who are pretty stable, but who clearly have something wrong with them, but who don't have a diagnosis, I would definitely consider sending genetic testing, because I think that now that it's more widely available, a lot of patients are going to get their diagnoses.
Thank you.
Amanda, that was a wonderful review. The congenital myopathies, when I was a resident, they were this sort of blob of diagnoses that were not really diagnoses. They were just pathological descriptions of what the muscle looked like, but there was never a clear pattern of what does this disease do and what does that disease do, because they were all being lumped together into a single disease, and it wasn't a single disease. So it's nice to have a little more explanation, more description of what these diseases are. And again, I agree with you that the presentation in adults is going to be, I would say that the presentation in adults is going to be one of 2 things. One would be probably the more common presentation would be that patient that shows up who just has this myopathy that runs in their family that has never been diagnosed, or they've been told of some pathologic description of their muscle biopsy, and they just say, well, I just have this kind of myopathy, and they usually mispronounce whatever the name is, but it's just kind of been passed down. And some of them have actually, some of them have been seen by all the neuromuscular gods, like they saw Dr. Emery and they saw Dr. Dreyfus and they saw all these experts way back in the day when we didn't have this genetic testing. And you can send off a saliva sample to Invitae, get them a definite genetic diagnosis, and they will treat you like a god, like you knew this, you figured this out, no one else could figure it out. So that would be the first presentation. And then the second presentation is that adult who is still ambulatory. They have just this kind of vague weakness, this weakness that almost appears static. They have a normal CK. They've never had a muscle biopsy, but they've pretty much normal development. They didn't, they met all their milestones, but you ask if they were, what they did in high school. They were not on the varsity team. They were not really on any sports teams. In fact, they were the kids who were the last one to get picked on the playground when you're picking teams. So they've always been kind of weaker, but it's never been enough of a problem to get looked into. But now that we can maybe give them a definite diagnosis, and it's very simple with the genetic testing that we have now. So. But anyway, thank you for that great presentation. One question. Do you think that there's has anyone done a relationship between the gene that has been identified and the morphology that has always been known, and why does this mutation cause this central core, or why does this mutation cause disappearance. Has that been done for any of these congenital myopathies?
Yeah, not that I'm aware of. That's a good question. But I read fairly extensively on the topic over the last year or so, and I didn't come across anything like that.
I think more of these are going to get diagnosed just because more genetic testing is being done. And so maybe we'll maybe figure out some of that stuff.
Yeah.
Well, if there are no other questions, go ahead.
Oh, I was just going to say, are there any other questions?
Aren't these virtual talks just the greatest? There's no applause. Thanks again, and
Right.
have a good day.
Thanks. Have a good day, everybody.